Welcome to POCUS Geek. I'm Jared Marks, and I'm going to work you through a very difficult case of cardiogenic shock and hopefully help you be able to recognize this in the future. If you'd like to test your skills and ability to interpret this before listening to this video, you can click on the card up here in the corner, or you can follow this QR code. That will take you to a video that is just the ultrasound itself, and embedded within that are opportunities to fill out a Google Forms and take a quiz. Essentially, that quiz is to answer these questions and see if you can interpret the cardiac ultrasound. Again, you can do that at any point. I'm going to leave the QR code up for a few slides. I am going to play the exam for you here quickly so that you can at least get an idea of the images before we review them and discuss each of you individually and what they mean for this patient. So we're going to go ahead and work through these questions. Again, if you wanted to try answering these questions, you can go to the other video and then fill it out. But I'm going to start working through each one of these binary questions with you. And so what we're going to find out is, yeah, there's cardiac activity. We can clearly see that. No, the left ventricular function is not normal. And so which one is it? It is actually depressed in this case. I don't think this is severely depressed. This is just mild to moderate depression on the EF. And then, is there fluid surrounding the heart or pericardial effusion? Yes, there is. No, there's not tamponade. There's no collapse of the RA or RV. The pericardial effusion is small. The left ventricle and the left atrium are both enlarged, the left ventricle being dilated and also the left atrium. Is the IVC collapsed? No, it's not. There's no variation on this. And then anything else. This is where it gets a little bit difficult. So this case is cardiogenic shock due to acute aortic valve regurgitation. So that aortic valve is abnormal. There is free fluid in both the intraperitoneal space, the right thorax, and then we've got B lines throughout the lung that we'll see in each one of these views. I'll go ahead and work through each one of these views with you, and we'll kind of we'll recognize each one of these, and hopefully that will help you recognize this in the future. So when we look here, I want you to pay attention that right here, just anterior to the mitral valve, we have essentially a very poor aortic valve. Something's wrong with it, and it's likely causing, or it is the culprit of everything that's going on here. We can see that there's B lines or interstitial edema in the lung. This would be the left lung. And then again, we can also see that the left atria is abnormal. Left atria is dilated when we look at our rules of 3. Here's a video up in the corner if you need to review that. And we're going to put these right next to each other. And what we're going to see is when the one on the right is normal, we can go ahead and see that the valve right here is collapsing, and it's closing on this side of the aorta, whereas over on this side we have prolapse, or this is coming back this way. And that aortic valve is just regurgitant. So when we look at the EF, we can see the EF is not normal as these walls are closing to each other. It's reduced. And what this is doing is it's dilating the LV. That's going to lead to increased pressures in the LA. So there's probably some mitral valve insufficiency, and that's going to back up everything from the LV backwards and get fluid in the lungs, fluid in the abdomen, fluid in, everywhere it is, it's going to third space. And so this is just a chance to recognize that. That is the key vital thing. And unfortunately in this video, we only see it in this one spot. We could assess this further by obtaining an apical 5-chamber view, which is not done in this exam, and that's okay, but just recognizing this would be our first step in knowing how to manage this. We can go to the short axis. Again, we're just going to remember that in a short axis, we're going to think of a dot right here in the middle and how much is it closing down to this. This view is a little bit off plane, and that's okay, but we can see that the EF is not normal. That's due to the acute episode of the aortic regurg. The LV has never built up the strength to pump against this, and is going to be a form of heart failure that's going to further exacerbate and get worse over time if not recognized early, and that aortic valve needs to be addressed. In the apical 4, there's not a lot we can do here to see differently. We could probably, as far as quality of this image, we could bring the probe back towards the patient's midline just a little bit. That would center up the The heart right in the middle, we could decrease the far field gain down in this area. That would just bring our quality up a little bit. But there's not much else here to do other than to see that the EF does appear somewhat reduced. But otherwise, what we could do here is you could drop the tail of the probe towards the wall of the abdominal wall of the patient or chest wall. That would give you a little bit anterior fanning, and that would bring in what's called an apical 5-chamber, and you would see the aortic root. Again, this may allow you to see that atrial valve insufficiency just a little bit more. You could throw color Doppler over that and really appreciate the regurgitation. That would be red flow coming back to you from that aortic valve and may key you in further on what's going on if you could recognize that abnormality in the other views. We go on to the subxiphoid view. Overall, we could decrease the gain on this image. That would help some of the quality. Again, we're given a chance here to see that the LA is big right here compared to the right atrium. It's a little hard to calculate the EF because we're just slightly off plane. We're cutting through this a little bit here, but decreasing the gain may help. And what we're going to see here on this next, I'm going to freeze this down, and we can actually see a small pericardial effusion right up here at the top. Again, this is not large, but we're going to be looking just anterior to the, or from the subxiphoid area, inferior to the right ventricle to be able to see this. And again, I'll play that. And it's very subtle on this, this clip view here we're going to have, but there is a small pericardial effusion there. So as we come to the subxiphoid short axis, again, we can turn down the overall gain. We continue to see B lines back in this area and the left lung telling us that there's interstitial edema. We do have a couple findings here. One is a pathology, one is an artifact. So if we look at this, we're going to see again that small amount of pericardial effusion marked in red. This blue portion is edge artifact, and that's going to be coming off the diaphragm. So this can be mistaken for fluid. This is not in this case. I'm going to go back to a live video so you can watch that. So again, we're going to have the edge artifact coming off of here. That's coming off the edge of the liver and the diaphragm, and then that small pericardial effusion here at the top. Next, we're going to go to the IVC view. And again, we can see in the IVC view that it's a little hard with the respiratory pattern, but we can see that there is no collapse here of the IVC. So no collapse from anterior to posterior. We are going to see fluid up here in the green. That is fluid below the diaphragm, which is right here. So there's some intraperitoneal fluid present. And then the diaphragm comes here, so we have all the right lung in this area, and we can see a small amount of pleural free fluid in this area. Again, we can tell that this patient is having a significant amount of third spacing, and we can better see the pericardial effusion in this view. And we'll go back to the live video and we'll see the pericardial effusion, the intraperitoneal free fluid, the thoracic free fluid, and that the IVC is just not collapsing in this case. So this is important for us to understand. What do we treat? So if we did not see that the aortic valve is abnormal, this could lead us to mismanage this patient. Acute aortic regurgitation is a true surgical emergency, and getting early surgical intervention can be life-saving in these individuals. Here is if you look at this article by Hemarani, then you can, it's a case where they discuss some of the important factors of diagnosing this early. And so as you get on, what I would do in this case is make sure I'm getting a hold of my cardiothoracic surgeon or facilitating that as quickly as possible. You may want to order a comprehensive echocardiogram or consultative echocardiography. And the reason why is because this is crucial. There's some tests that they can do that's beyond POCUS, in my opinion, to further evaluate how bad this regurgitation is. But everything here is indicating to you that this is acute decompensation of the heart leading to cardiogenic failure or shock with third spacing everywhere. And so what would you do to stabilize this patient while you're waiting for them to go to the OR? One thing you really want to avoid is decreasing their cardiac output. This is why it's important in this case. We can look that there's B lines, there's free fluid, the EF looks decreased to us, and that could at times cause us to give medicines that would decrease the cardiac output, and we really want to try to avoid that. What we want to try to do is decrease the afterload and increase inotropy. I hope that was helpful to you as far as understanding what we need to recognize in this case, and hopefully will help you to recognize any acute aortic regurgitation in the future and how that can play into a patient having cardiogenic shock. If you have questions about this or other point-of-care ultrasound related questions, please email me at pocusgeek@gmail.com, or you can comment below.